And welcome. It is the afternoon on the 20th of July. And we're going to be performing Duke laser disc repair, bilateral L3-4, and left L4-5. This patient has herniated discs and pain from the herniated discs in the back. So back pain localized to L3-4 and L4-5. So we're going to go in and do the Duke laser disc repair. Shot. All right, so 5, 4, 3. Looks like we're a little higher than we should be. You agree? Shot. So can you make 3, 4 lined up for me there, Jordan? We're going to adjust our X-ray so that we have a better view. All right, that looks good. 5, 4, 3. You agree? That is a big foramen, huh? Now this patient, Shot, suffers with severe back pain right at these discs that we're about to fix. Shot. Shot. Let's go AP. Nice big foramen. And I'm really happy we're not doing L5-S1 because that foramen looks really narrow. Whoa, look at that. Beautiful. Very nice. All right, so Henry, do you mind showing our audience why a herniated disc can cause so much back pain? Why is that?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. And now you can see why herniated discs cause so much pain. Yep, lateral view. It's simply because herniated discs, are we awake? Because we're ready for her to be awake. Herniated discs cause inflammation. Reliable? All right. We're fixing 2 discs today. L3-4, L4-5. Huh? Actually, do both on this side. Right, that actually.
Okay?
Yeah.
Can you open your eyes for me?
How long has she had back pain?
10 years.
All right. Shot? Shot? Yeah. How bad is that on a scale of 1 to 10?
Can you give us a number? Can you give us a number?
How bad is that? 10? All right. 10 out of 10 at L3-4. See, she's not arching her back anymore. There she goes again. You see that? How bad is that on a scale of 1 to 10? 10. All right, so 2 10/10s. Let's put her to sleep. You want to start? Why don't we start with, you don't want to start with that one? Okay, we'll start with the other one. Yeah, let's go. Thank you, Dr. Berndes. Do you see that arch? How she arched up? I mean, you don't even need to get like a verbal response these days. You just watch the arch, you know they're responding. That's painful. You know what I mean? Num num. Well, I checked on our last patient, by the way. He's doing okay. He's very sleepy, but he's waking up and responding appropriately. I broke the bad news to him, but he took it with stride. He knows we only got half the surgery done, and I told him we'll do the rest of it next week on Tuesday. He's fine with that. He told me he was planning to stay a week anyway. I cannot see this. Yeah. Can you see the hole? Can you turn the light a little bit, or?
Can we turn off that light?
Here. I see it, but I.
Work out well with his plane tickets.
Yeah, they were going to do a week anyway. And we'll get him done Tuesday. Shot? Shot. That's it right there?
Sir.
Shot? All right. Shot? Look at the herniation we're hitting right there. Isn't that cool? Do it. Shot? Shot? Big tear. Dilator's going in pretty easy. Shot? Go. Whoop. This time I got me. Luis is like, all right. One for the Gipper. I can't really see. Let me see. Shot. Looks a bit brutal, I get it, folks, but it works. Shot. We are inside the disc, and now we're going to fix it. You know, it'd be kind of cool, Luis.
Huh?
Never mind. I was thinking we could do 2 tubes at the same time.
We can. You want me to do another?
Nah.
Working tube, or?
I think in the future we might try it at a different location, you know?
Definitely.
Just to expedite things.
I think I've done like 300 cases with you.
Is that right?
Never had a patient in the recovery room ever mention recall during accessing the disc. During hammering that process.
Yeah.
Mention it online.
And they mentioned it online, yeah.
Well, they say
Yeah.
that it looks like it's.
It looks brutal.
Yeah, they say that.
They all get scared of it. They don't like it. I get it too. I wouldn't like it either. But I tell them, wait till you see orthopedic surgery. It's 10 times worse.
I totally agree. Watch a total joint online.
Yeah, those are brutal. By the way, speaking of total knees, we've now done over 10 Duke plasma rhizotomies for bad knees, knee pain, knees that need to be replaced, bone on bone, or problems with the meniscus. And all of our patients have their knee pain is gone. Every single one of them went back to work the next day.
We went back to work the next day, and it's a very easy, smooth anesthetic.
Yeah,
Require general anesthesia for that. It's nice.
it's amazing.
Really nice.
All right,
I love those cases. The patients do so well.
I know. Luis,
Yes, sir.
you like them?
Oh, yeah. The procedure?
The DPR knee?
That's amazing.
More than
Right? That's tremendous.
more than DLDR? Careful now. Careful. Careful.
Great procedure. Yeah.
I'm just joking with you, you know. For those of you who don't know what we're talking about, we've started to do a minimally invasive procedure to repair people's knees when they have knee pain from arthritis in the knee, and it's taking away the knee pain completely without putting them through a major surgery. It's done in 15 minutes, huh?
I'm excited for the hip joint,
Yeah.
right? That's the future, right?
Oh, look at the tear right there. You guys see the blue tear with the granulation tissue, the pink stuff on it right there? That's where all the pain's coming from. Look at that herniation. Here it comes. All right, so we're doing the training next week. And Dr. Patel feels that the knee's going to be the easiest, which he's already mastered. Then there's going to be the shoulder, he said, which will be second easiest, which I thought shoulder would be difficult, but, and then the hip is going to be the hardest. The hip may require some endoscopic assistance, just to make sure we're not too close to the femoral artery. And I want to do a piriformis release endoscopically. So we're going to practice that too. Yeah, piriformis, endoscopic piriformis. With this scope right here. Of course it is. It's going to be amazing. I'd probably be the one to do it. Using this laser right here, just release the tendon. It'll take me 10 minutes. It's about like carpal tunnel. With this, huh? Prone. Yeah, laying on their belly. 10 minutes, sedation, propofol. I mean, literally plant a needle. Probably using x-ray for me, not ultrasound. Patel likes ultrasound. I think the x-ray would be fine because I'm aiming for a different target than him. He's aiming for the muscle belly. I'm aiming for where the attachment of the muscle is to the femur.
So that's more of a radio.
It's more of a tendon release, whereas he's doing more of a muscle injection. Yeah, yeah. So, and then Davis will do it as well, I'm sure. So it'll be Patel. I teach Patel. He'll do it if he wants. You know. But basically, there's not going to be a single cause of back pain we can't fix. Cure with one procedure. Piriformis, SI, fractures, disc, facet, coccyx. Huh?
Now you have orthopedic pain and back pain. Because that's generalized orthopedic pain, right? You got the shoulder, you got the hip.
You're going to have the shoulder, the hip, the knee, the spine, everything. Eventually we can do foots. We can do anything.
I need you to do my foot.
Really?
I got a really bad peroneal tendonitis and it's infecting everything.
Tendonitis.
Yeah, it's like, and it's like,
Oh, so it's
you
tendonitis.
gotta stretch it and,
You got to talk to Patel because I don't know anything about that.
yeah, he wanted to do PRP.
Well, I don't know. He's the expert on the peripheral joints.
But I can't walk anymore, so.
Yeah.
Because they recommend when you have tendonitis, you should walk.
Listen, I would do what he recommends.
I went to my friend was a foot surgeon.
What do you say?
Don't walk.
Don't walk? He told you not to walk.
So, because I was walking like 5-6 miles a day.
Oh, you mean walk like exercise walk?
Yeah. So he recommended in the gym to do only the elliptical,
I see.
and the treadmill was worse than walking. I was doing more treadmill, so that made it worse. I did not know that.
So this disc was a 10 out of 10, concordant for back pain. This is the L4-5. I'm just about finished. Sorry, L4-5, right? Yeah. Then we're going to do the L3-4. One of the things you can look for on the next disc will be, you can see the needle on the other side, coming in from the other side. It's pretty cool to be able to see that. Right, Luis?
Oh yeah.
Just about done. 1 minute left here. How is our last patient waking up? There's a herniation right there. Yeah, I saw him. I saw him in the chair. I didn't know if he was more awake or not. Does he have a CPAP or not?
No, but he needs to be diagnosed. He needs to go to see a specialist. It's really
Poor
severe.
guy. Yeah. He needs to. All right.
Lights on, please.
I think we're done here.
Let's talk to
Yeah, we're done. Looks good. Henry, have we shown the video on how the discs cause pain?
Yes,
All right.
but not how the Duke laser disc repair works.
We did that one or not?
We did not.
Well, why don't we do that while we're irrigating?
Of course.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Why is there not an interface with a CPAP mask with a face that's more fluid? Like more, fluid.
We gotta remember, these CPAP masks are for one patient only.
I understand that.
They're just not.
But there should be a CPAP mask that, I need the knife. There should be a CPAP mask that is, pull that away. Yeah. That is, what do you call it? Num num.
When we kept the CPAP when it was working on his face, when we had it on him, he was doing it
No,
really
what I'm saying is if you have like a gel part that wraps around the face and interfaces, then it should comply to the facial structure. You understand what I'm saying? Shot? Shot? Yeah. Shot? All right. We're now doing number 3-4 on the left. Shot. Shot? Is that it? I mean, what I'm saying is if the part that touches your face is hard, then yes, it needs to mold perfectly, right? That's what I'm thinking. So with a gel coat, why wouldn't it meld to his face properly?
because of the
Shot?
nose when it protrudes out,
Mm-hmm.
it doesn't get the seal. If that makes sense. You can't get some patients with a different size.
We're just talking about, folks, how we can improve on our CPAP mask patient face interface.
Because you got to remember, CPAP, these masks are not built for prone. They're built for supine. So when we put them prone, you got to get it perfect.
All right.
Yeah. You know what I mean by that? 'Cause
Mm-hmm. Okay.
you're putting pressure on
All right.
the mask. But when you're supine, there's no pressure on it because your head is on the pillow like this, right?
But there must be some kind of prone CPAP mask that we can buy. I'm sure.
You got to look into.
Prone CPAP mask. Do a Google search. Do a Google search. I bet you there's a prone CPAP mask out there.
See, now we're brainstorming.
That's why we solve problems together. Grab her. All right, one down, 2 more to go. I can feel the needle in there. I was grabbing at it. Remember, there is a needle in here because there's one coming from the other side, since we're doing bilateral. So you're going to see it in a minute. And the thing about it is if I actually hit it with the laser, I'll melt the steel together. And then Luis will curse me under his breath for the rest of the day. Or maybe out loud. because it gets very hard to, go ahead and open and close it, the other one, just a little bit so we can make sure it's okay. Okay?
Yeah.
All right. Any questions?
No current questions, but we do have a comment from Trust on YouTube.
Hi, Trust.
And they said, looks beautiful to me. Brutal is a bloody open back surgery.
Yes, you're right. Brutal is pretty bloody open back surgery. Thank you for pointing that out, which I've done some open back surgeries myself in the past, a lot of them. Not bloody though, because we do minimize bleeding here at Duke Spine. Since everything is outpatient, we can't have too much bleeding, otherwise the patient would have to be transfused. But you're right, most doctors that do open back surgery, they do get into a situation where there's the tear right there. You guys see it? They get into a situation where they have to transfuse the patient because they get too much blood loss. It's weird because a lot of spine surgeons don't think it's their responsibility to help control bleeding. They think it's the anesthesiologist's job to manage the hematocrit. Right, Berndes?
Yeah, well, it is our job to manage it to an extent. I mean, everything has to have a balance. If you're losing 2 liters of blood, it's hard for us to do that.
Right.
But what I think
That's my whole point.
is that there's a limit to how much blood you can lose before there's major complications and shock to the body. It's called DIC, thrombocytopenia,
Yeah.
loss of coagulation factor. So it's a multifactorial problem when you lose too much blood.
What Dr. Berndes is saying is that even if you have blood ready for transfusion, it's still a bad idea to lose too much blood during any surgery, because if you start transfusing blood, you start getting into blood transfusion complications like mismatch and other things like fevers, immunoglobulin stuff. But you also have things like disseminated intravascular coagulation, or DIC, which could cause abnormal clotting throughout the body, or thrombocytopenia, citrate toxicity. Yeah. 12 different things, Dr. Berndes says, that are problems with losing blood. So my point is, as a spine surgeon, we're not taught to be conservative with blood loss. That's something that I learned when I got out and I started taking care of patients. Why am I feeling water everywhere?
You lose the least amount of blood of any spine surgeon ever.
Thank you.
What is it? Like, where?
Fucking hell. Dr. Berndes gave me a compliment. He said, of all the spine surgeons he's ever worked with, I lose the least amount of blood. I know what's wrong. I know what's wrong.
In fact, there's a lot of anesthesiologists that won't do spine surgery in the surgery center. Some of the older ones like me, they refuse to do it in the surgery center. They're not adapted to it. They don't like it. And they don't want to do it. But I think if you be careful with blood loss, there's no reason you can't do infusions in the surgery center.
What's going on with my fucking laser?
But it's all about patient selection. Outcomes are patient selection dependent. And surgery dependent, and anesthesia dependent. You gotta have patient selection, that's first.
Patient selection. I agree. Patient selection, very important.
Patient selection is everything.
To avoid complications.
That's the whole ball.
Yeah.
So that means good pre-op clearance, screening, medical clearance, cardiac clearance.
Yeah, optimization, selection. So this is the back of the disc. This is the last part we're going to be treating right here. We've gotten rid of most of the herniation. This is all scar tissue from chronic inflammation. It has nerve fibers in it that are very painful, pain sensitive. And you can see a little herniation there still. So I'm just cleaning this up. We call this an annular debridement. Annular debridement. Just technically, we're not doing a discectomy. We're not doing a laminectomy. We're not doing a foraminotomy. All of those procedures are highly destructive. They destroy the spine. We don't want to destroy anything natural or normal in the spine. The disc is normal and natural. The lamina is normal and natural. The facet is normal and natural. The foramen is normal and natural. Luis, I'm not getting to 12 o'clock for some reason. Yeah, that's a little better, yeah. Let's see, grab her. So what I'm getting at is all these open back surgeries that doctors do and people talk about, they're all destructive. They destroy the spine. And they cause harm to you, the patient. And the thing about it is that back then it was okay, because that's all we knew how to do, you know? Back in 1945, all we knew how to do was to drop a nuclear bomb. Nowadays, we realize that was really a bad idea. That we have, at the time, that was the best solution, right? But now we know that's not the best solution. So, same thing with spine surgery. Someday, we're going to look back on fusions and laminectomies and discectomies and foraminotomies, and we're going to say, hey, remember when we dropped the nuclear bomb? Yeah, that was bad. Remember when we used to do laminectomies? Yeah, that was really bad. That's exactly what's going to happen. And everyone's going to be doing exactly what you're watching. Duke laser disc repair. No, it's weird. All right, I can't turn it. It's too much. It's too much pushy. It's actually having an opposite effect of forcing it the other way. That's fine.
We have a question.
Uh-huh.
This comes from George Clooney.
George Clooney?
Clooney, yeah. And they asked, where are the nerves? Are you in the canal now?
Yeah, great question. So George Clooney, we are, first of all, we're inside the disc. So because we're inside the disc, you're not going to see the nerves. That's the beauty of this treatment, is that we stay away from the nerves on purpose. And we go straight to where the problem is, which is we need it here, man. That's the problem. We need it here too. Okay. I'll show you where the nerves are. They're outside of the disc, behind the disc. You're going to see one of them probably in just a minute here. Now, she had bilateral leg symptoms from these herniations right here that I've been working on getting rid of. These herniations are pushing on her nerves. Okay, right now I've forced the herniations back into the disc, and I'm removing them from inside the disc. I did that. Remember when I hammered that metal thing into the disc through the tear and the herniation? I literally put that up against the herniation and then hammered the herniation right back into the disc where it came from. And now I'm taking the herniation out from inside the disc. This is called the inside-out technique, okay? And endoscopic spine surgeons, they don't know this technique. This was taught to me by a master endoscopic spine surgeon, Dr. Anthony Young. We call him Yoda. He's Yoda, and I am Obi-Wan. And Luke Skywalker is coming soon. Right, Luis? Luke Skywalker will be here in 15 years. And of course, Dr. Patel is Gandhi, or we can call him Shiva. but he's not the god of destruction, so I don't know. What's a better name?
Jar Jar.
Huh?
Jar Jar. Jar Jar, that one from the Star Wars. What is it?
Jar Jar?
Yeah,
I was gonna say
You're
Mace
joking.
Windu.
Don't even say that. That's like an insult to him. What is Patel?
Obi-Wan's mentor, Qui-Gon Jinn, Liam Neeson's character.
Obi's mentor.
Yeah.
No, Patel's not my mentor.
Oh, I was just trying to find a Star Wars.
No, he's going to be an Indian character.
Oh,
like,
okay.
what is the Indian god of healing? All right.
Donvatari. Yeah,
All right.
Donvatari.
There you go. Like, yeah, that works. But Yoda is Dr. Anthony Young. Dr. Young is, of all the endoscopic surgeons, for the lower back, that is, not for the neck, he has the most experience in the world that I know of. He's done more cases than me. There's your nerve, by the way, right out there in the foramen. You can't even see it. I'm going to use the laser to clean this up. There's still a little bit of herniation underneath the nerve, a little bit of fat right there, kind of making it hard for me to see. But this right here, this stuff is pushing on the nerve, so I want to get rid of it. This is herniation still, and foraminal ligament. Ligament within the foramen. Foraminal ligament. I think she's going to do fantastic. Going to feel a lot better. Look how calcified it is. That's not normal. That orange golden stuff is calcium deposits. It's abnormal bone spurs forming. Right there. It's all herniation. This is lateral in the foramen. So somebody asked, where's the nerve roots earlier? The nerve root is on the other side of this tube, okay? We don't really want to see it because we want to protect it with the tube. But if you have to know where it is, it's literally to the left of the laser right now. Okay, just about done. 5 seconds. Should be done. Done. Here. Yeah, the nerve root is going to be right up in that fat up there. There it is. You see it? You guys see the white thing right there at like 10 o'clock?
Yes, we do.
That's the nerve root. We're just below it, okay? So it's protected by the tube in this type of surgery. And we're taking the herniation out from underneath it. One more to go, Berndes. Any questions?
No current questions.
All right, so far we've completed the Duke laser disc repair on the left side. We're going to move to the right side next. And we're doing only one disc on the right side. I got it. Shot. $7mm incision. Num. Dr. Berndes told me the other day he wants to finish his career out here at Duke Spine. Isn't that right, Dr. B?
That's true.
That was a huge compliment to our team, to Duke Spine, to our patients, our success as an organization. Shot? Hold on. Let me see. Shot? Yeah, looks good. See this part right here that everybody hates so much? I'm actually hammering the herniation back into the disc. That, I'm literally, the bouncing is because you're hitting the herniation. It's so rubbery with all the scar tissue, and it's bouncing you back. I can feel it. So I'm literally pushing the herniation back in. And then I take the herniation pieces out from inside. Shot? All right, that's good. Last one, 10 minutes left. Shot. Looks good. I'll do this. Go ahead. All right. Why don't you staple? Thank you. I got it. Down the home stretch. 10 minutes, Dr. Berndes will be done. Scope on, laser, or grabber. All right. So why is it a little more bloody on this side? Let's see who can figure that out. Anybody know? Huh? Oh, this side looks different, doesn't it? It's got, at least in this area, less herniation and more kind of scar tissue. The reason why it's bloody on this side is because remember we did the other side already, right? And the blood is actually going from, scope a laser on, it's going from the muscle where it oozes a little bit down the track that we created and into the disc and through the disc to this side. You can turn that off. Yeah, it's right on my eye. Thanks. Boy, look at all that calcium. More herniation. There it is, 5 minutes.
Let's do passing to like to and prime for, please. Yeah, thank you.
Oh, that's a big herniation right there. One piece, small. The nice thing about this surgery is if you do it properly, it's virtually impossible to damage any of the nerves. But there's a lot of little tricks that I do to avoid damaging the nerves. Grabber. Henry, any questions?
No current questions, but we do have a comment from Trust once more on YouTube. And they said, "Thank you so much, Dr. Duke."
It's my pleasure, Trust. Thank you again for trusting us. I cannot see any more herniation. I'm trying to grab, there's a piece right there. That was the last one. Let's see if there's anything more. I just don't see anything more, so I'll do another grab in there, and I just don't see anything else. Let me just finish right here, and then we'll be done. 2 minutes. Thanks so much for joining us today, folks. And if there's no more questions, I'll just have Henry end the broadcast. Like I said, our last patient, we're going to do the rest of his surgery on Tuesday of next week. He will be our first surgery, and I've already talked to him, and I told him we couldn't finish his surgery because of his, issues with the anesthesia. So he's okay with that. We're going to do the removal of the spinal cord stimulator lead, scope off. We're going to do the second disc, and we're going to do the Duke plasma rhizotomy for the facets. Then, of course, we have 4 more surgeries that day. So we've got a single-level cervical DLDR for herniated disc, another cervical single-level herniated disc, and then we got 2 lumbars, I think, on that day. So Tuesday will be a 5-surgery day. Nice job. Here, let me, yep, that's what you got to do right there. That's the move, my friend. Go. Let me have a stapler.
We have just one question,
Yep.
and this just comes from George Clooney once more on YouTube.
All right.
And
I'll take
they said, "Can this be done at the neck? And what's the difference with that and a microdiscectomy?"
Oh yeah, for sure. So first of all, Mike, I guess there's 2 questions.
Yeah, it's
Can
a double question. Yeah.
Yeah, can this be done in the cervical spine or neck? Yes, absolutely. We do it all the time. On Tuesday next week, we're doing 2 of the neck ones, 2 cervicals. So come watch. But yes, we can do the cervical Duke laser disc repair. And then what's the difference between this and a microdiscectomy? Microdiscectomy, the surgeon makes the cut in the middle of your back. They literally destroy your muscle by ripping it off your spine. We don't do that. Then they get to your bone in the back called a lamina, and then they cut half your lamina off. It's called a hemi for half, a laminectomy. They take half your lamina out. It destroys your spine. And while they're doing that, they also take out your facet joint. It's called a partial facetectomy. All that's part of the microdiscectomy code. So they basically destroyed, it's like cutting off half your knee joint, and half your femur, and then saying, hey, we went in there and clipped a toenail. So it's just pointless to destroy all that normal stuff just to get to the disc when you can go around the spine like we do. We come from the side. So we don't destroy anything to get to the disc. Whereas a microdiscectomy, you're destroying all the normal stuff. I'm going to call her EBL 2 mil. No complications. So it's a DLDR, bilateral L3-4, and a left L4-5. Everyone agree? Thank you very much. You all do great rest of your day. And Henry, are there any other questions?
No current questions. Can we end it off by showing the what is a microdiscectomy video?
I love it. Let's do that. You can watch the video and see what a microdiscectomy is all about.
A large incision is made. muscles are torn from the spine. Substantial bleeding occurs due to muscle trauma. Normal, healthy bone is removed to access the herniation. Stabilizing ligaments are removed in order to access the herniation. An incomplete portion of the herniation is removed. Dense scar tissue forms. Weakened bones can fracture, leading to instability and pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www